and your institution. It looks like you're on mute. Raphael, we'll come back to you in just a minute.
There we go.
Oh, okay, go ahead.
Hi, my name is Rafael Martinez. I'm Director of Behavioral Health at NOAA.
Great. Welcome, Raphael. Glad to have you. Okay, let's go to Sarah Pedraza. Sarah, go ahead and introduce yourself.
Guys, can you hear me today?
It's a little quiet, but we can hear you.
Okay. So Sarah Pedraza, Behavioral Health Consultant, MHC Healthcare.
Great. Thanks, Sarah. Let's go to, who's next? I see the username ARUP, A-R-U-P-P. Can you hear us? Okay, we'll come back to you. Let's go to the phones. Let's go with the, actually, let's start with Eric first, the 602 number.
Hi guys, thanks Matt for having us. My name's Eric Gosland. I'm the owner and managing partner of Evolved MD. We're a behavioral health resource group based here in Phoenix, Arizona. And we currently operate 13 fully integrated primary care behavioral health sites here in Metro Phoenix.
Wonderful, thank you, Eric. Let's go to the next phone number. I see 928-527-7850. If you'll go ahead and introduce yourself. It looks like you're currently muted, so we can't hear you. Is it *6 for phones?
Yeah, *6 for phone to unmute if you're having trouble with that.
Okay, 928, we will come back to you. So let's start with ASU people. Adrian White, you want to go first?
Hi, yeah, thanks, Matt. Good to see everybody. My name is Adrian White. I'm the director of the ASU ECHO programs. And I just want to make a quick announcement here. If anybody on the call here does not have access or is currently still having trouble getting access to our member portal of our ASU ECHO website, please send me a message in the chat and I'll make sure I do some work behind the scenes here to get you access.
Great. Thanks, Adrian.
Thanks.
Let's go to Dr. Leslie Manson.
Hi, everybody. I'm Leslie Manson. I'm also part of the ASU team here, and I'm also working with CHS and the Doctor Behavioral Health Program.
Wonderful. Thanks, Leslie. Let's go to Tyler.
Hi, my name is Tyler Dunnington. I'm a former graduate student helping with ASU ECHO here. Thanks for joining in. Quick thing here. So if you have, or if you're new to the meeting, feel free to send in, or new to ECHO, feel free to send in your information, just phone number and email address to this ASU admin account, and we'll get you a part of our list so it's easy for us to contact you here. Thank you.
Great. Thanks, Tyler. You can send that directly to him, admin, through the chat. Let's go to Mahalit next.
Hi everyone, I'm Mahalit Walker. I'm an undergraduate at Arizona State College of Health Solutions as well, and interning for the ECHO program. Nice to see you all.
Welcome, thanks Mahalit. Let's go to, I think that's one of our students, Tabark. Tabark, can you hear us? And go ahead and introduce yourself.
Hi everyone, my name is Tabarak. I'm studying public service and public policy at ASU. I'm looking to get involved in Project ECHO this upcoming year, and I'm an undergraduate.
Wonderful, thanks Tabark. I see some new people joined us. We're doing introductions, so if you go ahead and tell us your name and your institution. Let's go with Darren Reeves next. Darren, can you hear us? It looks like you're muted. You can unmute yourself by clicking on the microphone icon in the bottom left-hand corner.
Can you hear me?
Yes, yes. Yes.
Great. This is Darren Reeves. I'm part of the ASG Baptist Health Behavioral Health Integration Team in Arkansas. And my medical director is also on, Patty Gibson.
Oh, wonderful. Welcome, Darren. Glad to have
you. Thanks. I'm a social worker, by the way.
Okay, great. Let's go to Patty Gibson next.
Hey, this is Patty Gibson. I'm a psychiatrist and the medical director of our behavioral health integration team in Little Rock, Arkansas. We're in a system of 24 clinics, and we have 10 people on our team. So we're looking forward to learning what we can.
Okay, wonderful. Welcome, Patty. Let's see. Let's go to Ash Rupp. Can you hear us? Can you introduce yourself?
Can you guys hear me now?
Yes, yes. Yes, go ahead, Ash.
Oh, okay. Hey, yeah, I'm with the Williams Guidance Center. It's an offshoot of the Flagstaff Guidance Center in Flagstaff.
Oh, okay, wonderful. Welcome, Ash. Okay, I think that's everyone. So welcome to ASU ECHO. We meet bi-weekly. The next meeting is going to be on June 28th, 2 weeks from today. We meet at 12 p.m. It's currently Arizona time, but also Pacific time. And the purpose of ECHO is really to bring people, like-minded people together to learn from one another. It's a learning network, and we're focused specifically on effective management strategies for behavioral health integration in primary care. And the way that ECHO works is at our meetings, we do didactics, just a little bit of teaching from someone as part of the ASU team, and then we go into case presentation. And the cases are helpful because it's an opportunity for us to learn from each other, to give recommendations as well as support for people who are looking for specific feedback on a challenge that they're dealing with. And we'll have a case presentation later today. I'm going to do just a reminder about the website, and I'm going to share my screen. Adrian mentioned this. So I'm sharing my screen, and you should be able to see the website here. We're still building this, but it's currently functional, and there is a member portal right here. And the member portal is where you can look for upcoming trainings. So for example, well, actually, the one that was upcoming is today, so that's gone now. We'll put up the other sessions later. So yeah, you can see this one is the one that we have today. And when you click on that, you can get all of the meeting information, including the time and the Zoom link. We will also send this information out through email, but the website is another great way to get to it. If you missed a session and you want to watch the video, these meetings are being recorded. You can, let me go to one that has a video. You can go to that particular session and you can watch that recorded meeting. Each of our meetings are about an hour long. So that's the website. We're also looking to put some resources up there. You know, sometimes it's hard to find a place that has a lot of aggregated information about integrated care management. And so we're hoping to put a list of those resources right here. So to get access to that, you just have to send your name and email address, and we'll give you access as soon as possible. Okay, let's see. I've seen a few other people join us. Let's do 2 more introductions. Yash, if you'll go ahead and introduce yourself.
Sure. Hi, everyone. My name is Yash Suri. I was a graduate student, but recently graduated, and I'm a part of the ASU ECHO team here.
Okay, wonderful. Thanks, Josh. Let's go to C. Wade. C. Wade, if you'll go ahead and introduce yourself. You're currently muted, so you may have to unmute yourself. You can do that by pressing *6. I just heard something. Try it one more time.
Can you hear me?
Yes, yes, go ahead.
This is Cindy Wade. I'm the practice administrator for Flagstaff Family Care, and we have behavioral health integrated into our primary care here in Flagstaff.
Awesome. Welcome, Cindy. We're glad to have you.
Thank you.
Okay, so like I mentioned before, we do didactics at each meeting, and today is my turn. So I'm going to be talking about medical provider training. I'm going to pull up my slides. Okay, can you all see this?
Mm-hmm.
Okay, and
Yes.
are you seeing the presenter mode or are you seeing the full screen mode?
Presenter mode. You need to switch it.
Okay, let me switch that.
There you go.
All right, thanks, Leslie. Okay, so this is something that has been an interest of mine. I'm a licensed marriage and family therapist, but I spent about 8 years training medical students and medical residents. And so I've been looking into how to better prepare medical providers to succeed in integrated care. Workforce development is an extremely important part of making sure that integrated care works. And so I'm going to spend just a little bit of time talking about recommendations and some possible resources that might be helpful to you. So first, the value of training. This makes sense to most of us, but it's helpful to have a reminder about why training is important. First of all, it's essential for integration to work. Integration is usually transforming your practice, creating new pathways, new workflows, and for people to succeed in those new care processes, they have to know what their expectations are, their responsibilities. So it's essential for integration to work. Training is also important for clarifying people's roles and their self-efficacy. One of the drivers of burnout in healthcare is a lack of role definition, role clarity. When people are not really sure what their expectations are, they can feel a lot of stress and a lot of confusion, and training can help to eliminate that. It can also help providers to feel empowered when they understand what they need to do, when, and with who. Your BHPs can also feel an increase in support when the medical providers have adequate training. It can also help to resolve any misconceptions, misunderstandings about what integrated care is. Sometimes the medical providers may think that it's only about a certain type of patient population, or maybe it's only about substance use. Whatever the misconception might be, training can help to resolve that. So that being said, it's valuable, but there are a lot of challenges, and one of the main challenges is time. Training takes time, and in a busy practice, taking medical providers away from seeing patients costs money. It's also hard to find content out there for medical providers. And this is one reason why I've gotten involved in this area, is that it's hard to go online or to go to some of the training institutions and find a curriculum for medical providers. That this is really an underdeveloped area in the field right now. And third, there's something that I call model muddiness. This is where a particular site may not have completely decided what their model of integrated care is going to look like. They're not really sure what role they want the behavioral health provider to play. They're not really sure what their business plan is going to look like. And when that's the case, it can be very difficult to determine the role of the medical provider when there's really just a lack of clarity about the entire model that the site is using. Fourth, and this one I think is common, is some sites, they just forget to train all of the medical staff, the nursing staff, the medical providers. They've been very busy in hiring a BHP, in developing these new pathways and learning more about the billing and the coding, that they just forget to train the medical providers. I think that happens pretty often. And then finally, another challenge is that sometimes we just assume that the medical providers are going to fit into this, this new model, that they're going to figure it out over time. And, you know, that may happen for some of the medical providers who are very sharp and they pick up on it, but it's more valuable to avoid that assumption and go straight for the training. So here are some recommendations. The training is going to look different for each site, and it really depends on the needs of your particular medical provider and site. So I recommend beginning with the end in mind, focusing on the workflow, and making it motivating and easy. So first of all, beginning with the end in mind. First, determine what model of care you're using. So for example, in the collaborative care model, the medical providers probably need to know about patient registries, and they also need to know about validated behavioral health screening tools. That could be part of your training. That training may not be as important in other models of care. So first decide what model you're using. Then find out what are the PCPs interested in. They may actually have a good sense of their gaps in knowledge and skill, or something that they're just interested in, and you can help to address that. Find out what the requirements are at the payer, state, and federal levels. So for example, there are some states that require the medical provider to endorse or sign off on the BHP's note. In that case, the medical provider probably needs to understand what a BHP note looks like, how to sign off or endorse it, maybe also how to interpret the note as well. Second, focus on the workflow. In my experience in training medical providers, many of them just need to know what you expect of them. You know, what are the skills? What are the responsibilities? What do they need to do at certain points? And they'll do it. They just need to know what it is. So determine how specific you need to get with those responsibilities in your training. That can really help to shorten the training time as well. Number three, you'll also have to determine what are the informatics or the electronic medical record tools that you need to develop, or that the medical providers need to learn about. There might be specific screening tools that you're going to integrate. There might be a specific way that the medical provider starts a referral and then pushes that referral through. Just think about all those things that they need to learn how to use. And then also think about if you should train the whole team together, the medical provider and the nursing and the BHP together. And think about what other team members might need to be included as well. And then last, make it motivating and easy. If possible, find a champion at your site. This doesn't need to be a leader. It's usually someone who is committed to integration, who has a sense of the vision of what it needs to become, and have that champion be a part of the training. Also determine when is the best time to train. Maybe it's during a lunch hour, maybe it's in the evening. It'll have to be a time that fits the needs of your particular site. I'd also recommend recording the trainings, and not just the seminar or workshop that you develop, but I also recommend recording how to use a particular clinical informatics. So this might be how to generate an internal referral for BHP. Some medical providers may not know how to do that referral. So what you can do is you can use your computer and provide a tutorial or like a walkthrough of how to do that referral process, and then record that while you're doing it, and then make that video available to the rest of the medical providers. So if they ever forget how to do an internal referral, they can just watch that video again. And then finally, it's sometimes easy to forget that we're not talking about the rationale or the why, but behind why we're integrating. And that can be a part of your training as well. It doesn't need to be a big part, but you can spend some time just talking about the kind of clinic that you want to eventually become, the kind of service that you want to offer to the patients. You can even invite your champion to talk about some of their particular patient cases where integrated behavioral health was very helpful. So like I mentioned before, I've been involved in this area of research for a little bit. We just had a paper come out on 22 essential skills for family medicine residents. And we're starting another project to see if these skills are applicable to other disciplines in primary care. So this publication is available. So when I send out these slides to you all, just click on that red text there, and you'll go to the publication, and you can see the 22 lists of essential skills. And then when you see them, just think of ways that you may want to adapt them to your own training. You might see some skills that you hadn't thought of that you want to implement. The second thing that I want to share with you is that we use that list of skills to create a curriculum. Now, the curriculum was tailored for medical residents, and we just finished a pilot that showed that the training was helpful to the residents. But this curriculum is available to anyone. So you can click on that link, and actually I have when you click on that link in the slides, you'll be taken to this website, and you can enroll in this course and complete it. It takes about 2 hours. There is a workshop that's attached to it that you don't have to complete the workshop, but it is a nice way to practice some of the skills that are talked about in the modules. Now, this is an ongoing project, so this training is still available, but we're probably going to continue to refine it, improve it over time. But just remember that it was originally designed for medical residents, but it may be useful for whoever is at your site. Okay, so I'm going to stop there. I want to make sure that we have plenty of time for Jennifer, but I've just covered a pretty big topic in about 15 minutes. Are there any questions or comments about medical provider training? Anyone that wants to share maybe their experience with it?
I think the residency curriculum is awesome. I wish it was around back when I trained. So good job for developing that.
Thank you. We had a pretty good response from people who liked it.
Have you found any difference in training established primary care physicians as opposed to residents, in terms of their openness or something that you need to focus on differently?
So that's a good question, Patty. So in my experience, and I'll let others chime in my experience, it's easier to train the residents because they're more eager, open to the training. They have fewer misconceptions or perceptions about what integrated care is like. Also, I had a lot more control over their schedule. I could choose when to train them. I had more time to train them as well. So if I wanted them to spend maybe 2 or 3 hours shadowing a BHP, I could do it. That would be very difficult to do with a medical provider in practice. So that's been my experience.
Yeah, that makes sense.
Matt, I'll chime in with a real quick comment. We spend a lot of time training, both initially and ongoing, and what I would say is obviously the initial engagement with these providers, whether they're established PCPs or residents, is important to the overall success of the program. But we commit a lot of time to ongoing training, and I think when we look at the providers that are referring into the program, it's number one, they need to understand the value of the program and why they should refer patients. But so a lot of the training is also focused on habit change, right? These providers have managed patients in a certain way for a certain period of time, and changing those habits is difficult. But to me, it's training on the program, understanding how to leverage the resources, but also working to change habits and ensuring that these patients get resources that they need. And that's just an ongoing process.
Eric, I appreciate that, especially the comment about the ongoing nature of this training. I think it's almost impossible to completely train medical providers in just a 1-hour luncheon. It really has to be ongoing training, bits and pieces over time, especially when they have certain perceptions about what integrated care should be. The training, if it's happening slowly over time, can help to change those perceptions and habits, like you mentioned. Great comment. Any other comments or questions about medical provider training?
Yeah, Dr. Martin, I can comment. In doing this at my own practice and my own research on the subject, I think what I also found is that for providers to invest their time and change their habits, it really had to be patient-centered. You had to describe the patient benefit in order to get them to really invest and start making some changes. So just to add that.
Mm-hmm.
Yeah, wonderful.
Mr. Martin, I had a question about, you had a question on there, you said, is it better to train them in groups? So what was your opinion on that?
Yeah, so I would say yes. The challenge then becomes time and also the scope of your training. When you're training them in groups, you can easily show them how they collaborate, how they work as a team, who does what, when and where in the entire care pathway. The challenge, though, is that you can't go into a lot of specificity with the particular skills. So if you train the entire team and you have an hour, that means that you can't spend a lot of time talking specifically about what the medical provider does or what the nurse does. You're mainly talking about the entire team. But I do see a lot of benefits from team-based training. One other comment: sometimes the nurse or another team member is not completely aware of what the other team members are doing. So when you train them as an entire team and they learn about what so-and-so is doing or what so-and-so is responsible for, it helps to expand their vision for the entire service. Okay, great question. So I'll send out those slides. If anyone has any comments or questions, please feel free to email me. This is an area of interest for me. Okay, so at this time we're going to move into our case presentation by Jennifer Thomas. This is an opportunity for us to learn about another site and to learn about the successes that they've had as well as the challenges. It's also an opportunity for us to give feedback and recommendations. So the way that we do case presentations is we first have the presentation. So Jennifer will present, and then after that, I'll give a brief summary of the situation just to make sure that we all understand. And then we'll spend some time just asking some questions, clarifying some things, and then we'll move into recommendations. And the way we usually do that is we start with non-ASU people first, because we want them to be thinking and offering solutions first. So Jennifer, if you want, you can go ahead and share your screen if you've got your slides, and the floor is yours.
Oh boy. Okay, thank you. Sharing my screen. Oh, I'm so not tech savvy, guys, so bear with me. Okay, so if I hit present, tell me if you're seeing anything.
Not yet.
Not yet. Okay.
So if you go down to the bottom of your Zoom screen, there's a little green box there that says share. Click on that, and then it should give you some different options of screens that are available. You can share your desktop screen or just the PowerPoint presentation.
Okay. Sorry, tell me one more time at the share. Click on share. Okay. And then
just select what screen you want to share with us.
Okay, probably this share, and then go back to slide 1, I guess. Is that anything coming through on your guys' end?
Yes, we have your presentation up.
All right, great. Bear with me. I'm a family doc. I don't do computers. Or I do them, but it's because I have to. Okay, well, thank you guys for giving me the opportunity to share our integrated care work. My name is Jen Thomas. I'm a family doc with Morris Hospital. I'm our director of integrated care, and this is a brand new position, like 2 months in, so I'm definitely a novice, but hoping to get good information from you guys that have been doing this a long time. I also had a unique training opportunity last year. I, out of a Google search, stumbled upon a primary care psychiatry education opportunity with UC Davis called Train New Trainers Primary Care Psychiatry Fellowship, and that's how I got into this whole integrated care work. So kind of wanted to share my story with that too, because it was definitely a good luck moment to stumble into some good teachers on that topic. So Morris Hospital, as I said earlier, we're located 55 miles southwest of Chicago, small, independent, nonprofit hospital. So just because we're outside Chicago does not mean we're suburban, we're rural. The two clinics I'm at are towns of 2,000 people, so we're a half-hour drive to the grocery store to Walmart, so we're not a suburban location by any means. But we do employ lots of docs, primary care and specialty. We have 23 primary care sites around the county and the surrounding counties, so we're the biggest employer in the county, so we have a lot of captive patients and a big Medicaid population. So that's sort of a background on what Morris looks like. We got started with integrated care with a co-located model in 2017. We hired an LCSW and plopped her in my primary care site and an OB site, and worked well, but we found that it wasn't our best go at integration. So we are trying to shift to the collaborative care model. So our integrated care work, we think of it in three prongs: the collaborative care model, and then educating our existing PCPs to do more on mental health topics through the fellowship that I did with UC Davis. The purpose was learn more about evidence-based treatments for depression, anxiety, and then the train the trainers part is take that knowledge back to your home hospital, home institution, and share it with your other primary care providers. And then our third prong is just to develop better relationships with other community providers, local health department, organizations like NAMI, food pantries, things like that. So that's kind of how we conceptualize our integrated care work at Morris. So just to review, you guys probably know tons about this, but collaborative care introduces 2 new care team members to the work that a PCP does with a patient: the care manager, who's located at the PCP office, and then a consulting psychiatrist. So it's team-based care where patients are treated by the team and tracked in the registry. So we're using PHQ-9 not only to diagnose the depression, but also track scores over time. The care manager and the site consultant meet weekly for 1 hour to discuss the caseload and send messages to the PCP about treatment recommendations. So again, this is the fellowship that I did. I found it really helpful. It was doable for a full-time family doc. On the surface, you think, oh, a fellowship, who can do that? I can't take a year off work and go back to school. But the curriculum is scheduled for people that work full-time. It's a year-long program. Now, it's not a CGME fellowship where you go back and be a resident for a year, but it's still extremely helpful. You have 2 one-hour webinars a month, one hour mentor discussion with a psychiatrist where you can go over, SSRIs or discuss tough cases, whatever you need it to be. And then there's 2 intensive in-person weekend training. So it's doable. And again, the vision is to then take that knowledge and disseminate it back wherever your full-time job is, train the trainers. And how I'll be doing that now that I'm graduated from the fellowship is we're going to have some didactic sessions every couple months. The fellowship curriculum goes over things that walk into the primary care office on a regular basis: depression, anxiety, bipolar. At one of the weekends, we got some really nice training on motivational interviewing and some even basic CBT stuff that even primary care docs can pull out a little bit. We're by no means masters of those techniques, but it was really neat to have a few more tools in the toolkit. And then, we'll discuss our challenging cases as a group. So that's one thing we'll be doing with our integrated care effort. So we also, with our whole integrated care journey, stumbled upon a really fortunate relationship with the AIMS Center out at the University of Washington. In my fellowship, I first heard about collaborative care January 2018. So being, I guess, the PCP champion that I am at my institution, I was like, hey, maybe I'll just email AIMS and just see if they'll even return my email and see what they could do to point us in the right direction. And luckily enough, they called us back and they're like, sure, we've got a perinatal depression study going, and if you guys at Morris wanted to jump in and enroll your center, we could train you in collaborative care for free. So our administrators loved that, and they're like, sure, give it a shot. So we started doing some weekly implementation and coaching calls with AIMS last summer. And then we started developing our workforce. So last fall, we hired a full-time LCSW for our first care manager role. And then we hired a consulting psychiatrist. She's located in Springfield, Illinois, so she's about 2.5 hours south of us. And her contract is for 4 hours per week to do this collaborative care model with us. So then in January, AIM Center staff came all the way from Seattle to Morris, Illinois, and they did core team training. So it was a group of about 8 of us in the core team, and then they had some lunch and learn sessions. We trained 23 of our PCPs over that lunch hour, and then we had some other attendees, hospital administrators, social workers, so 50 people in all got trained. But again, that was just a lunch and learn. The core team was the one that got the 2 full days of training. And then we kicked off back in February. We started at a primary care site in Gardner, where I'm located, and then our Morris OB site. And then since then, in March, we have tried to continue expanding our workforce. We hired an additional half-time LCSW and then a half-time LCPC. So my questions for the peers, I guess, would just be to pick you guys' brains and say, hey, who's doing collaborative care, and does it work with Medicaid? We're finding in Illinois that our Illinois Medicaid doesn't reimburse for the 3 collaborative care codes. So, you know, is it financially sustainable if Medicaid does cover this? If not, are you guys looking at billing traditional psychotherapy codes? Our trainers at AIMS were suggesting maybe looking at that as a financially sustainable model if Illinois Medicaid won't reimburse the codes. And again, most of our patients in the program are Medicaid insured. And then just 2 other questions for you guys of how you've educated PCPs. Thank you, Matt, for touching on education. That's definitely some good info that we'll take away from today's call. And liability, just in talking with PCPs, I've gotten a lot of questions like, well, what if you guys get sued? Or, you know, does this change our liability? Are we exposing ourselves to new risk by being the psychiatrist? Things like that. So what would our target ideal state look like? We definitely will need to develop a screening protocol. Right now, it's kind of ad hoc. If a patient comes in with depression, we might say, oh, we have this thing called collaborative care. Here's our warm connection to the care manager. So being a little more purposeful in how we funnel patients in would be good. And then we just like to expand it. I mean, our utopia is that we have collaborative care at all primary care sites. We're nowhere near there, but that would be a good thing to have in the end. And of course, an effective billing strategy, because keeping the doors open to do the work means we have to be sustainable. So our current state, we've got collaborative care at the 2 pilot sites, Family Medicine, where I work in Gardner, Illinois, and then our Morris, Illinois OB site. We plan to roll out collaborative care at a 3rd site at a MedPeds pediatric practice in June, and then a 4th site at an internal medicine practice in September. Again, our administrators are saying, well, from a perspective from the budget, you're losing money because they're looking at the cost of, well, our LCSW salary and the salary of the psychiatrist. And again, the fact that Illinois Medicaid is not reimbursing currently those 3 collaborative care codes yet, although we just got an email, some CFHA member sent me a cool email that I guess the Illinois Senate has a bill on the floor of the House or Senate, I think it passed both houses, to cover collaborative care codes. So stay tuned, that might be a good thing for the state of Illinois. So what our barriers have been, just finalizing the consulting psychiatrist deployment. We've got her contract all done, but our recent hurdle has been that she needs hospital privileges and credentialing. So again, she works in a different institution than where we are. The AIM Center staff says, well, most consulting psychiatrists don't need privileges where they do this type of collaborative care work, but our medical staff is saying, no, she needs privileges. So right now we're in this holding pattern where she's applying for privileges, but that could take a few months. So we're trying to get a temporary psychiatrist on board. We have a telepsych group that we work with at our ER to hopefully fill in this role until we get our psychiatrist fully credentialed. And then the referral to specialty mental health. We know that some patients' needs are going to exceed collaborative care. Those with schizophrenia or maybe a very tough bipolar case, they might say, okay, we need to get specialty mental health on board. But again, most of these patients have Medicaid, and right now where we practice, the health department in Grundy County, Illinois, is the only other mental health provider that accepts Medicaid. So it's sometimes a 3-month wait to get in. So we're going to look at troubleshooting that as well. And then some of our PCPs are just reluctant to utilize collaborative care. A few of our holdouts are things like, well, we don't want to be more of a psychiatrist than we already are, or what if we get sued, things like that. So those are just a few barriers that we've come up with. So community partnerships, again, we're trying to do a better job talking with our local health department to help get patients in a timely fashion for their initial assessment. We want to involve other organizations, the grassroots group NAMI, National Alliance on Mental Illness. We'd like to strengthen our relationship with that local affiliate. They have programs for consumers, so patients with diagnoses, and then family. They have a great family-to-family class. We've been talking with them about kicking off a class this fall. And then We Care, that's a local food pantry, clothes closet. They did a really nice ACEs, Adverse Childhood Experience class for parents back in the spring, so we're trying to develop some programming with them. So yeah, in summary, that's what we're doing at Morris. The three arms: the collaborative care work, the educating existing PCPs more with the fellowship curriculum, didactic sessions, and then those community partnerships. So yeah, does that make sense? I know I talked too fast, but that's kind of where we're going at Morris, and be happy to get any feedback from you guys. Go back to slide 11, I think was the questions for the peers.
Yes, yeah, we're doing great, Jennifer. That was a great presentation. There's a lot happening at Morris.
Yes, hopefully we're trying anyway. So yeah, is anybody doing collaborative care out there? I'm sure a lot of people are.
Well, before we jump into that, let me just give a summary.
Great.
And then we'll go into clarifying questions and then
great
questions. So Jennifer, it sounds like you did try integrated care with an MSW at first. And then that did not work out. So then you moved towards a collaborative care model, and you got some special fellowship training, and then you got some training through the AIM Center, through the perinatal depression study. It sounds like you have a care manager at the LCSW who's full-time, 1.0 FTE. And then the site consultant, you're hoping to eventually get to 4 hours per week once they're fully hired. It sounds like you've done a lot of training for the PCPs and the other hospital staff. Your main questions for us today are about collaborative care model billing and coding, especially in Medicaid. You have questions about sustainability and maybe even using some traditional psychotherapy codes. And then there was a question about PCP education, which we can certainly discuss if other people have ideas. Yeah, so a lot, you mentioned some barriers. We can certainly talk more about those. But let's go to clarifying questions. So if anyone has a question, you can unmute yourself and state your question. You can also do it through the chat as well. So any clarifying questions?
Can I ask a quick question about the registry tool? Obviously, this is one aspect of collaborative care. Can you tell us a little bit about how you guys are managing patient data within a registry?
Yeah, so with the AIM Center, because we're part of the perinatal depression study, we have access to their program. Their registry is called Caseload Tracker. We have it for free through the end of 2021. They have products that you can purchase from the AIM Center. They even said you can use a spreadsheet. So there's different ways to do the registry, but if that's something people are looking at, the AIM Center is happy to either set people up for one at cost or even potentially set one up yourself without a cost associated. But does that answer your question?
No, that's perfect. Thank you very much.
Sure, okay.
Is your registry incorporated into the EHR, or is it the one that's separate from the EHR?
It is separate, yeah. That is one challenge we're having. So there's a separate login, but it's pretty doable. I mean, as a PCP, I'm not running the registry list on a regular basis. I have access to it just to know from our QI project, but most PCPs don't use the registry. It's the care manager and the site consultant that use that tool on a daily or at least weekly for the site consultant basis to run the list and look at whose PHQ-9 scores are, increasing or not getting better, to know who they need to do a psych review for and things. But yeah, it is outside of the EMR, unfortunately.
Good questions. Other clarifying questions for Jennifer? Other things that you want to know about her site? the model that they're using.
Jennifer, can you talk a little bit about patient throughput? What are you guys seeing as far as capacity on a daily basis, caseload?
Yeah, so again, we're just kicking this off a couple months in, so we're very much in the infancy stage of our program. But the guidelines from AIM Center say that one care manager should have 60 to 80 patients on their personal caseload max for a high needs safety net, high Medicaid population. But again, it could go up to 100 plus for a less patients with maybe some less socioeconomic needs. So probably 60 to 80 is where we're shooting. And our one case manager is already full. I mean, we could have filled 3 or 4 up, I think, from the get-go. There's such a backlog of need. But yeah, 60 to 80 is the ballpark of one care manager for most Medicaid.
Thank you.
Mm-hmm.
I'm curious about what your how your hospital was motivated to create this program and what the current funding is since you're not billing. Are you part of any initiative or grants or anything?
Yeah, that's a great question. I mean, our motivation, it came out of really a PCP-driven voice of we're the PCPs, we see the Medicaid patients, we are not having access to specialty mental health because, again, our local health department, it could be 3 months to even get an initial eval, and we're like, we need to do something to improve our behavioral health integration. So we just said we've got to try. That's why we initially tried the LCSW model. We had a relationship with a private practice site group, and it just didn't pan out for us. So thankfully, our administration was open to trying an integrated care approach. So financially, yeah, right now we're relying on some philanthropy from local donors. We've got some grant applications out there, but yeah, financial sustainability is our big hurdle right now. AIM Center tells us, though, that states that do have Medicaid that cover the 3 collaborative care codes, things look pretty good for them, that they are able to be sustainable. But again, we're not to that point where we've been able to study if Medicaid covering it in Illinois, and hopefully they will, but right now they don't. So that's definitely a big challenge for us, is the financial sustainability piece.
Good question. I had 2 questions for you, Jennifer. The first one was, have you had any contact with Illinois Medicaid to see if they have any suggestions for other alternatives, other strategies? Go ahead.
Sure. So in Illinois, all our Medicaid have been tracked into, I think it's one of 6 MCOs, managed care organizations. We're contracted with 2 of them, Meridian and Allina Care, and we've had meetings with both of them to advocate for them to cover collaborative care codes. We've got a lot of, that's great idea, but if it's not on the Illinois Medicaid fee schedule, we really can't help you. So, I mean, they do cover traditional psychotherapy codes, so that's where with our LCSW, we might look at, having her just bill for her time. When she does her CBT work, she might just, bill a traditional psychotherapy code if it comes to that. But yeah, we're very much in a pilot, got to see what we need to do and what could work situation right now.
Matt, are you ready to chime in for other suggestions, or?
I just had a second question was, are there any specific diseases or health problems that you're targeting in the model?
So, I mean, depression, anxiety is our main target. What we're finding, though, in just the last couple months is that when we start looking into patients' mental health needs, we're uncovering such a wide variety. I mean, we're finding a lot of patients have a lot of trauma. There's several of mine that we're like, wow, you have PTSD, you meet criteria. We're finding more mood disorder. Our group is doing a better job of asking and identifying substance abuse issues. So yeah, I would say we started off with the let's do better treating depression and anxiety, and we're just finding that we've just got a backlog of need. But I think that's a good thing. We just got to figure out a way to actually make a difference in some of these things we're finding.
Yeah, that's been my experience too, and that makes sense considering your patient population. Okay, great questions. Let's move to recommendations. Leslie, do you want to start with you?
Sure, if you'd like me to. So I'm very familiar with a lot of the implementation of this model across the United States. Most sites do struggle with financial sustainability, regardless of which state they're in. There's actually a number of things to consider. A lot of the other organizations have done the kind of like a different approach. They'll see this approach as one of the service lines to continue to have implemented. And then what they'll do is they'll build a PCBH model within their organization as well. So then they can bill legally, the other codes. So you'll have both kind of types of, you have two different types of models or service lines running at the same time. That's going to give you the best financial sustainability related to it. You can also look at some of the other states. You can also look at what they've done with really targeting the legislation and saying, we would like to advocate for this to be put on our Medicaid. And you can do that. In fact, you can actually do that with the individual payer systems there as well. Sometimes they'll kind of play dumb a little bit, but the more you get your other kind of community health centers involved, and you can write some letters related to that. I actually worked with 2 states to do this, to get specific codes put on and voted on, and now they are up and running and on. So you can do it. It will take some time. Usually it takes about a year or 2 to get that really going, but that's really not that long if you think about it. However, you will need a contact with that and a pathway to do it. So you're going to need to make sure you know how to do that. It starts with your CEO because they're normally they're the representation for that type of change.
Sure.
I'm more than happy if you're looking for anyone to look at some of your current, finances and what your reimbursement rates are, what you're getting from Medicare and how many patients you are. I'm happy to run some return on investment models for you so you can see very clearly and plainly in mathematics whether or not this model is going to be, helpful and substantiate itself in the long term if you got Medicaid. There are 2 other primary large-scale private insurances that are covering those codes now too. So looking at some of that population is good. Most people transition over not to do depression, anxiety. They're doing more of looking at the larger complex concerns for mental health because technically the codes are written for those more complex concerns. So that's what you're finding is pretty much what everybody has kind of.
Good to know.
Yeah, PTSD. And remember, part of this model is to choose individuals who actually do the care management that are unlicensed, uneducated. They are typically individuals that are more of an MA function and level or at max bachelor's level.
Mm-hmm.
So that really changes the dynamic of how much you pay, which also helps with being able to have some level of sustainability. And knowing that you have social workers, that's a different model. So that's a higher cost model. So that's the difference between most of these individuals doing care management are being paid, let's say, $30,000 to $40,000 max a year, whereas social workers probably being paid a little bit more than that. So you might want to consider those things or dual rolling your jobs with the nurses or other people that are on play already. So there's a variety of things that people have already done to help with this. Again, I'm more than happy to donate some time and services if that's something that you all are interested in. So.
That'd be great. Thank you.
Leslie, we're curious about how programs are dealing with patients having to pay co-pays.
Yeah. So it depends on which visits and which codes you're doing, right? So it's the primary care that's going to be actually doing the billing portion of this. They shouldn't be, with Medicare, there's high copays. I mean, it could be $40 for a lot of Medicare patients and they're on fixed incomes, etc. So it depends on the code and the frequency of that code. So if they're coming in and you're billing it, every month, and again, depends on the code. And if you're going to do the other model, there's going to be a copay for them too. You just have to bill it. You can't not collect it, but what you can do, right? The Federal Anti-Inducement Act says it's illegal. So what you can do is a lot of places have built on the back end for the codes that require the copay. They build on the back end a way to basically wipe it out for the patients if that's something that you all need or want. So there is a systematic way to look at it. You can also look at how you're billing and bundling your billing related and looking at how you place your patients into your regular general system. These patients are probably already coming into your system monthly. So they're already being seen, right? So you want to see when you're dumping these codes on as far as it throughout the month. There might be a way that some sites have kind of dual coded on the days where they know that they're coming in. Does that make sense? Along with that other, so they don't have to do the double copay.
Yes.
So
thanks.
It takes some, looking through it.
Mm-hmm. what elements are needed for to build a PCBH model? I'm not familiar as much with PCBH as collaborative care. Is it possible to build both, you were saying, or is that not necessarily what we're doing?
I try to look at it as service lines. So you're just looking at different types of services that can be delivered. The primary care behavioral health model is just another type of model. And the AMs and other areas will also talk a lot about how for them it's really being kind of molded into that. You know, there's a lot of it splitting so that they can get financial sustainability. Basically, it's just a service model where a way to describe it very easily is to say your case manager, your case worker, your social worker, your mental health clinician of some kind, or behavioral health, become someone who's not simply doing care management, because that's technically their role is communication care management, very brief. They're actually doing more interventions. So if you look at the collaborative care codes and the definitions, those care managers are not doing therapy or full interventions. They're helping to bridge and do communication and build all that and communicate with the people who are doing interventions. Okay. Mm-hmm. So they would have that other role, so they can actually bill for the other role. You'd want to make sure that the billing is set up. And I mean, I have lots of people know I have all this that is already set up, so you can just take it and here's the documentation templates. Here's the billing. This is how you define the two scopes so that you can do it all legally. It's very easy to do. And depending on your site, you could be making much more money because you can bill from anywhere from 17 minutes all the way up.
Awesome. Okay. Good to know.
Great recommendations. Other recommendations for Jennifer in regard to billing, sustainability, different.
I'll throw a quick comment out there to address one of the questions about sustainability that national coverage and Medicaid coverage. The good news is I would like to report that if Medicaid coverage is in play, this program is sustainable, and obviously there's a lot of variables that come into play on that, as far as what type of providers you hire, how many patients you see a day, but even at the highest level of licensure with licensed clinical social workers, master's level, seeing, call it at a minimum 4 to 5 patients a day with Medicaid coverage, this program is sustainable. All of the national commercial payers, including the Medicare Advantage plans, are paying and covering for the service. The one for that is Cigna. And then in our state, Arizona, all of the Medicaid MCOs are currently paying for this program. So, based upon the demographics of that population, the Medicaid population and coverage is a must. But once that trigger is pulled, this program can put your practices in a very good position from both a clinical and an economic perspective. So it is viable. It just requires some variables to come into play.
Great. Thank you.
All right, we have just 1 minute left. So Jennifer, thank you so much for that presentation. That was a great case. And
thank you, my pleasure.
You get a chance in the near future, maybe in the next few months or so, we'd love for you to come back and give us an update on how things are going.
Great, we'll do.
Okay, and thank you to all of you who attended and shared your questions and recommendations. So just a few items. We're going to be sending out an email with a link to a survey. We are looking for feedback on how to make this ECHO group even better. And we're also looking for specific topics that you want us to cover in the future as well. So look out for that email. Also, if you are interested in doing a case presentation, maybe not as well as Jennifer did today, but maybe just as well in the future, please let us know. We'd be happy to give you some time to do your own case presentation to get feedback and recommendations. And then finally, our next meeting is going to be in 2 weeks. That's June 28th at the same time. That's 12 p.m. Pacific Standard Time. I hope everyone has a great weekend. Thank you.
Thank you.
Do you guys want to stay on for a little bit? So the ASU team, you want to stay on?
Yeah.
Sure.
Okay. I see Yash is on. Okay, and Mahal, it looked like you had to have two.
Yeah, when I clicked on the link to my audio, oh wait, can you hear me?
Yeah, we can hear you.
Oh, my audio was just